another important session, which we usually miss, or it is not diagnosed very commonly. So it is underdiagnosed. That is delirium. So many patients presents with some confusion, hallucination, etc. And many may not understand why it is so, what is the problem with this, what should be the underlying causes, etc. So today we are going to hear more about this from Dr. Roop Gursahani, who is a neurologist working at PD Hinduja Hospital in Mumbai. So he's even though he's basically a neurologist, he is very much interested in palliative care and in epilepsy.
Raj, I'm giving
And he is an advocate of advanced care planning, and he's a founding member of ELICIT, that is End of Life Care in India Task Force. And he continues to be engaged in lifelong pursuit of discovering what it means to be human. Welcome you, sir, and it's over to you.
Right. So I'll just share my screen. Can you hear me?
Yes, sir. We can hear you. You can share the screen, sir.
Yeah, I'm just doing that. Screen. Oh, there's some problem with screen sharing. Yeah, I think now. Yes, got it?
Yes, sir. We can see it.
Okay. Thank you for the introduction, and thank you again to everybody from Pallium for involving me here. Now, I'm a neurologist. Of course, my major interests are in palliative care, but I'm going to be speaking partly from the perspective of a neurologist. And it may interest you to know that delirium is something that I really knew very little about till about maybe about 10 or 12 years ago. I mean, I knew it, but I'd never really seriously read it until I had to prepare a lecture some, I forget where. And since then, it is a topic that has fascinated me. And then, as my interest in palliative care grew, it obviously became a more important entity. And you will realize that this is something that we are never taught about. Not during our undergraduate days, not when I was doing post-graduation medicine, not even in neurology. And then the last problem is that it falls between multiple specialties: neurology, psychiatry, internal medicine. And it is, as in so many things, everyone's responsibility is no one's responsibility. So let's begin with the story. And I'm not sure how many of you can identify this sinister looking object here. It's something called a taser. It's an electric stun gun. So if it's shot at you, it gives you a bolt of electricity and just knocks you out. So here's the story. This was a Polish workman who planned to immigrate to Canada, and he landed out down in Vancouver sometime in October after a long flight. And as he came through immigration, he was traveling with his mother, and they got separated. So the mother went through immigration, got stuck in baggage claims, and he was on the other side, and they just could not connect. So lost, confused, unable to speak English, he used office chairs to build a makeshift barricade to ensure that no one could remove him until his mother came to meet him. And then he lost his temper, began to throw computer equipment. The police were summoned, and in a stunning sequence of events captured as usual on video, he was pinned to the floor, shot by a taser to quieten him, and he died. So this is the excited delirium syndrome. I told you I was going to tell you a story. I didn't tell you that that story would be about palliative care, but still, it tells you what delirium is. Now, the excited delirium syndrome has multiple signs, and these signs are all reportable signs, because obviously you're not going to be able to do a clinical examination of a patient like this. But look at the estimated risk of death in an episode of this, over 6%. And this has possibly a basis in excessive dopamine in the brain, triggering manic excitement, which can have both a genetic basis and can happen perhaps even in normal individuals, to the point that it affects the autonomic system and causes death. There have been very few post-mortem reports. And now, if you hear these stories of somebody who was picked up by the police and had some kind of a situation um, with possibly a history of stimulant abuse, and he died, you know that this is perhaps an example of the excited delirium syndrome. But these are obviously rare situations. So let me show you two more cases. I know that there is another case that is coming right at the end, but you'll understand how these all overlap. So this is my own patient who was actually had been treated for breast carcinoma. It was okay, and then one day she got headache, went to sleep after lunch. When she woke up, she was lethargic, confused. She had clear-cut meningitis, and when she was treated appropriately and in time, she was completely normal. And then an older woman comes in with a fracture neck femur, comes to our hospital after 2 days, and we saw her for preoperative fitness. And we realized that she was a little cognitively down, possibly because of a minor stroke. Post-operatively, she was agitated. She needed sedation. The sedation led to aspiration, led to an ICU transfer. She stayed 10 days in the ICU, and when she was discharged, her mini mental score, which is like a very basic mental status examination, had dropped almost a third. And even 1 year later, it hadn't probably recovered. So she had been left with a certain amount of permanent deficit. So the best way to understand delirium is to think of it as acute brain failure. Now, it could happen to an individual who's otherwise completely normal, a normal brain, perhaps genetically prone, but with overwhelming either physiologic or pharmacologic stress. Or case two is a normal individual, maybe older, but otherwise completely normal, gets an acute neurologic insult, again recovers. And the third situation is a vulnerable individual who can get either an acute or a subacute systemic insult and can go down equally rapidly. And I don't need to point out to you that typically the patients that we see in palliative care will be closer to case three. Now, if you look at the predisposing factors or risk factors and the precipitating factors in delirium, you will see that it becomes a kind of a continuum. So if you have a very severe precipitating factor and a normal individual, it takes sepsis with multi-organ failure to put them into delirium. Whereas you have somebody with dementia, even uncomplicated UTI can put them into delirium. And obviously there are all grades in between. So the more cognitively intact a person is, the bigger the insult that it takes to push them, and vice versa. Now, we have to recognize three clinical types of delirium, and I have shown all three of them to you in the cases that we did. So the first was hyperactive, agitated, restless. In the hospital, this is somebody who's attempting to remove catheters, tubes. There's emotional lability. Hypoactive, somebody who just becomes drowsy. And this is the one that very often is not recognized because these are flat. The effect is flat. They're apathetic. They're lethargic. The responsiveness is low. And you just say, so good. So, and of course, you have the mixed one where you get a combination of both. And typically, it's when somebody has features of the hyperactive type, either intermittently or continuously, that is when people recognize delirium. Now, how often is this seen? Well, hypoactive is and mixed are the vast, overwhelming majority. Probably something like over 98%. The pure hyperactive type is pretty much uncommon. And you can see that. I mean, it's not something that would probably happen in a otherwise normal individual. So when you look at delirium, basically you're looking at alterations in arousal, and you have to understand that you have only 2 points that are very clearly defined. One is alert, which is somebody with a perfectly normal state of arousal, and the other is coma, which is completely unresponsive, in which the patient lies with the eyes closed. In between, you use terms like lethargy, obtundation, or stupor, where somebody can be roused. The problem is that only the terms alert and comatose have enough precision that they do not require any further qualification. Everything else requires definition, because otherwise you can get quite confused. Now, again, you kind of look at these in terms of two broad features. One is attention, and the other is arousal. Obviously, if you do not have arousal, you cannot have attention. So there is this kind of link. So consciousness is defined as a state of awareness of self and surroundings, and any alterations of attention or arousal, well, you can term them acute or acute on chronic brain failure. Whereas those patients who are um, who have no alterations of arousal, who are completely awake, may still have some deficiencies in attention, but more importantly, the content of consciousness can be impaired because of dementia, psychosis, depression, and these are the alterations of cognitive and affective mental function. You can understand that these terms do tend to overlap and flow into each other. So, what are the features of delirium? The first is a reduced ability to maintain attention to external stimuli and to shift attention to new stimuli appropriately. Somebody who's uh, unable to focus on the question that you're asking, disorganized thinking. So they will be speaking and their speech will be incoherent. Or obviously memory impairment. If you are not able to pay attention, then new material does not get retained. So obviously when checked for memory, that's deficient. Then because these people have uh, distortions in perception, so they will have illusions, they have hallucinations, and something that distresses family very much is the inability to recognize people who are close to them. You may have increased or decreased psychomotor activity, but probably the one feature that is very reliable on the history is a disturbed sleep-wake cycle. So this is somebody who, if you ask, will have stopped sleeping in the night, instead dozes off throughout the day and is awake and confused through the night. And this may be the first feature that the family notices. Then when you check them, they are disoriented in time. They don't know where they are in place. Their mood can change. And there is a lot of fluctuation, especially nocturnally. Once it is dark, there's a lot of tendency to exacerbation. So essentially, you have to have a change in thinking. So there's disorientation, difficulty in speaking, memory problems. And one issue is that this should not be accountable for by purely by dementia. So dementia is a major differential diagnosis. And more importantly, this is something that has developed acutely or subacutely. So over a period of hours, days, maybe maximum weeks, fluctuates through the day, and often it worsens at night. And that worsening in the evening it has been called sundowning. But when you check it, there is one cardinal feature of delirium, and that is the failure of attention. So the individual's ability to focus attention on the here and now, that is what makes the diagnosis of delirium. And to understand it, you have to understand that the brain, the various brain parts are, well, the brain as a whole is a stage, and the various brain parts are actors. It's the spotlight being attention, that brings one or the other, or maybe the whole cast into play, uh, into action. And you can understand that probably the most likely reason for this to happen is that there is poor communication between the regions. And that has been confirmed even neurophysiologically. So basically, the networks that uh, connect uh, functionally are the ones that deteriorate. So either there can be a functional loss or a structural loss, but either way, it produces the same problem. There are many pathways to brain failure. In people who do not have structural abnormalities, also, you can have various neurochemical mechanisms of delirium. So it can be like hypoxia, hepatic failure, sleep deprivation. And you can see the kind of neurotransmitter abnormalities that occur in any of these situations. I'm not going to go into the details of this because obviously there's no time for this. But to point out that if you look at the variety of mechanisms, obviously the etiologies are going to be as diverse. And there are two mnemonics which you are welcome to try and remember the details of. So delirium itself, Delirium, and you can add an S, which is subdural hematomas. Drugs, eyes, ears. So somebody who has visual impairment, hearing impairment, so sensory deprivation, they can lapse very easily into delirium. Low oxygen states, various kinds, infection, obviously, sepsis. Retention of urine or stool. This is something that is big in palliative care. Remember that one of the things that you need to learn as a palliative care physician is how to do a manual evacuation of feces. That's an essential skill. And cystocerebral syndrome. Well, I have seen I had a patient who got admitted with us, and he had rapidly declined. His memory had rapidly declined, although he had a previous dementia. And he stayed for about 3-4 days in the ward, and we couldn't figure out what was going on. And then we had to send him for a sonography for something. And then I get a call from my resident saying, sir, he has his bladder is 2.5 liters. And we catheterized him, and his cognition actually improved. So ictal, people who have epilepsy, they can get delirious, and uncontrolled pain is something that should not happen in a palliative care unit. So that again is something that we need to look at. So this is the simpler mnemonic, but if you want a more dramatic one, this is it. I watch death, and I'm not going to run through the various components of this. You can look at this, but to add that poisons are also possible in the acute situation. What about the most common admission diagnosis in a palliative care unit? Cancer. In cancer itself, because of its byproducts, because the pro-inflammatory cytokines can produce delirium on its own. But there's a whole host of various components of oncologic, the disease, the diagnosis, and the treatment that can all produce delirium. And for us in neurology, probably the most important is to make sure whether there is intracranial involvement because of the cancer. It could, of course, be primary, but it could also be secondary, say seizures or a cerebrovascular accident. But you can see almost everything that I've pointed out before is possible in cancer. Now, one of the things that you need to do when somebody is, say, for instance, in a medical unit, and you may have to assess them for delirium in advance, is to look for risk factors. Now, some factors are baseline, like age, you can't modify it, and something called ApoE4, this is a risk factor for dementia, hypertension, prior cognitive impairment, alcohol. Now, these are baseline risk factors. Acute illness related risk factors, we've already discussed how they can work. And there are certain hospital related risk factors which we will come to. Now, there are various components in these which are potentially modifiable, and we need to pay attention to them. And as we go on, I will be speaking about them. These need to be clinically assessed when you are, say, for instance, seeing a patient for say, preoperative fitness, or if you are admitting a patient even in a palliative care unit. You need to be aware of these features because these are what can lead to delirium during admission. So we've already discussed them. So in addition to having somebody who has already cognitive impairment, also look for mobility impairment. Just the sheer fact that somebody is not walking around too much. Usually impaired mobility, of course, if it is say acute orthopedic, it may be different. But if somebody is just not walking too much, these two go together. Visual or hearing impairment, this I can, you know about this, and I mean, I have told you about it, but I have one of my aunts progressively went down because she refused to come to the hospital, even though we had realized that she had bilateral cataract and she was completely deaf. And finally, we had to literally drag her into hospital and do her bilateral cataract surgery, and she significantly dehydration, sleep deprivation, history of alcohol misuse. These three things often run together. Multiple comorbidities, especially those that are linked to the brain, those are also obvious. So these are things that you must be alert to when you are, as I said, either doing preoperative fitness or admitting a patient to a palliative care unit. But now I come to the real crux, the problem with delirium, or the problem with assessing consciousness. You will have realized that this is pretty much an inexact sign, and yet people have called it the sixth vital sign. So the problems are that assessing this is difficult. I mean, you can try standardizing and making it reproducible, but you have to make it simple enough for paramedical staff. And then it has to link on to follow-on interventions where outcomes can be studied. And as you can imagine, if you have been reading up palliative care, you'll have realized that when you assess palliative care needs, there's a whole host of instruments that can be used because uh, you have different ones for different needs, and perhaps none of them is really perfect. And the same thing applies to delirium. You have so many uh, instruments and checklists that it becomes difficult to figure out what to do. So I'm going to focus eventually on two, but I'll start with this one. This one is probably the first one that was published. No, there was a couple earlier, but this one was the most prominent one. It's called the Intensive Care Delirium Screening Checklist. Uh, the IC DSC is the short form that's often used, and here you look at various points together with level of consciousness and give a total score. Then, of course, you have people who are in the ICU and cannot communicate because they are intubated. So you can use visual attention screening examination. This pairs in with the ICDSC. And here you show them pictures and ask them to point at pictures that they have or have not seen before. Now, this, of course, as you can understand, is not terribly easy to do. And then you have the two-step method, which uses assessment of level of awakeness or sedation. And here you have somebody who's alert and calm going up to the patient like Zikansky, combative, violent, danger to staff, which actually is a stepwise progression for somebody who's anxious, but movements are not aggressive. This is frequent, fighting the ventilator, then pulling the tubes, and then combative. And on the other side, somebody who awakens, who once awakened, stays awake, or awakens with eye contact or voice, and then goes back to sleep again. Somebody who's just eye opening, and so on down. So these are like the pain faces. These are also depicted as faces for nurses to use, but I prefer to use the numerical scale instead. And the next step is to confirm that this was acute in onset, that there is inattention, and you do look for disorganized thinking and altered level of consciousness. And again, I'll explain that in the next one. So there are two scales that we use commonly. This one, the 3-minute diagnostic interview, uses the confusion assessment method. This has been fairly well standardized, and but this typically has to be used by trained personnel, and it is something that can be repeatedly used. So it's it has fairly good inter-observer reliability. It also has decent reliability for multiple users in the same patient. So here you start off by first figuring out whether the patient has an acute change in mental status. You can ask the patient that whether they think that they are confused. And I often ask the patient, do you think, are you okay? Are you feeling okay in the brain? Can you think clearly? And if they say yes, then you go on. But if they say no, I'm sure I'm not very clear. So what is it? Are you seeing things that are not really there? Basically asking for hallucination. Or if, as the observer or the nurse, were there any fluctuations? Fluctuation, speech, thinking. The next is you actually assess attention. So the attention is assessed by giving them a simple task, very simple. Digit span forwards, backwards. So you give them, say, tell them that I'm giving you a short phone number. Now, remember, most of us were used to keeping about 7 digits forward and 5 digits backward. So 7 digits forward, which is why I think that as long as it was the old landline numbers, we could all remember them. Now with mobile numbers, typically not everybody remembers the full 10 digits unless it's your own and it's something that you learned over a period of time. So typically, most people should be able to remember 7 digits forward. But here we are looking for digit span backwards. You give them 4 numbers and ask them to do that. Or you tell them to say start with Saturday and tell them to tell you the days of the week backward or months of the year backward. Tell them December and say batao. And during the interview, you can assess whether the patient had trouble keeping track or was easily distractible. Then, if you want to find out if they know where they are and what they are doing, then you ask them to state the current year, the day of the week, and where they are. So typically, you'll have somebody saying, I'm at home or I'm at my son's place, whatever. And again, how good is the speech? Was it easy? Was it unusually limited? And then, of course, you watch for was the patient sleepy? In fact, if the patient falls asleep during the encounter while you are examining them, that is obviously a sign that this is somebody who's impaired. So you put this together. So if you have a positive answer in feature 1 and feature 2, then either of 3 or 4, and you made a diagnosis of delirium. And this is a test that can be repeated. There are scoring possibilities also on this, but we won't go into that. Those are really for research methods. But I'm going to now take you to something that I use routinely at the bedside, and this has been called the 480. You'll be able to get it. It's very easy to access and to download. It's free. So this actually checks for 4 items. The first item is alertness, which we've already assessed. If you remember, somebody who's normal or at the most mildly sleepy, which means he might just be a little drowsy for about 10 seconds, but then wakes up. Versus somebody who's clearly abnormal, which means anything more than falls asleep in the interview or anything more than that is 4 points. If somebody does that, then you really don't need anything more because you're already at possible delirium or cognitive impairment. If they are alert enough to interact with you, then you ask them simple things. What is your age? What was your date of birth? What is this place that you're in now? And which is the current year? You would think that this is not something that anybody can make mistakes with. You'll be surprised. We find this so often. Then, of course, you check attention by looking at months of the year backwards and then confirm whether these features are acute and fluctuating. So if you see anybody who scores 4 or more has delirium, a possible delirium or cognitive impairment and needs further assessment. So 480 is a very quick and easy test, which anybody of us can use, and we should actually be using regularly. It takes less than 2 minutes. There's no special training required. The only thing is that in an awake patient, they can learn it even although they are limited. So it is basically just a screening tool, and anybody with 4 or more needs a more detailed assessment. But as I said, this is something that everybody can use. Uh, Now, checking attention alone is not enough. You also have to be aware of the various mimickers of delirium, and there are three that we need to remember: dementia, depression, and psychosis. In dementia, please remember that this is a chronic story, but except for that, everything else can mimic delirium. As I said, this is chronic, so you won't get an acute change. And this needs to be assessed by finding out from the family what the patient's uh, level of functioning was before they got admitted. So we call them the activities of daily living, and you know that from the other scores in the scales that we use, like the Karnofsky and so on, you will know how somebody is functioning in day-to-day life. And obviously, patients with dementia will be fully conscious as well. What about depression? They may have altered psychomotor activity, so they may be slow, but in fact, they will not have any altered consciousness. Obviously, this is not an acute story. And when you do a detailed assessment, the thinking is fairly clearly organized, as opposed to psychosis, which can sometimes be acute, where people may or may not have problems in giving attention, but both disorganized thinking and altered psychomotor activity are present. So this is one of those. This is probably the entity that quite often troubles clinicians in distinguishing between uh, psychosis and delirium. Now the challenges are people do not screen objectively. The diagnostic terminology is all confused, um, and uh, the hypoactive subtype often doesn't get identified. There's multifactorial etiology, and as I said earlier, whose responsibility is it? Psychiatrist, physician, neurologist? Who? Unfortunately, everyone's is no one's. So how frequent is it? Well, in the general medical ward, it can go up to 30%. In the post-operative, in anything that is major, 50 to 70%. In the ICU, depending on the kind of patient, as much as 80%. So obviously, it is not something that can be infrequent in palliative care. But if you realize palliative care occurs in a multitude of settings. So if you look at, and these are various studies that have looked at the incidence and prevalence of delirium. These figures that I have taken are the median figures across studies. So if you look at cumulative incidence during admission in a inpatient palliative care unit, about a third. But when these patients are towards the end of life, just prior to death, or in all during admission, it can go up to 60%. What about inpatient medical oncology? Again, 25%. But as I said, just prior to that, it goes up to about 60%. If you look at people who are in the community, the highest figure was about 50%, but patients probably fluctuate between 20 and 50. What about at the end of life? In inpatients, wherever it has been assessed, it's almost 80. Uh, I mean, I would take it that somebody who's actively dying is delirious unless proved otherwise. But in the community, perhaps the figures are smaller and just about 40%. That may be because it's not always clearly assessed. Now, if you do get a patient with delirium, what are the various things you do? Now, I have taken this from a standard text to tell you what is the flow of management here. And then, of course, I'll focus on how this changes for palliative care. The first thing is you have to institute supportive measures. And these supportive measures are obvious hydration, avoid restraint, mobilizing the patient, reducing noise, reassurance, managing pain, and so on. Then uh, medications. Now, here this will depend on what the patient is, what you are managing the patient for. But remember that our responsibility is to correct the correctable. So, if unless there are very clear indicators or directions that this is a patient who's in hospice where no further investigations are to be performed, these are the basic minimum that we would normally do. We look through the list of drugs for offending drugs. Look for a history of trauma because a subdural hematoma is something that can very easily be tackled and tapped. You look for again focus of infection. So, for instance, even though somebody is in palliative care and has had a decent quality of life, a simple UTI is not something that you would leave without treatment unless there was a very specific mention to that effect. And then, of course, if you have uh, obvious CNS infection, then you need to be prepared to handle that. And then again, there it really depends on the stage that that patient is in. There are many drugs that can contribute to delirium, but the most prominent are the benzodiazepines. Then, of course, opioid analgesics, uh, other sedatives, antihistamines. The other one after benzodiazepines that everybody needs to remember are various anticholinergics. And even drugs that are not primarily anticholinergics but have an anticholinergic component, you have to remove them from that list. So antidepressants would come up there. Anti-Parkinson's agents do not have anticholinergic activity, but because of the way they increase dopamine, they can also produce delirium. And antipsychotics, if they have anticholinergic effect, have a dual effect. You use them to control it, but they can also worsen it. Then, of course, barbiturates work the same as benzodiazepines. So, in the medical setting, if if there is no obvious etiology, then we do look at other stuff like vitamin levels, thyroid. We might do an EEG, MRI, drug levels, and so on. Maybe not totally appropriate in palliative care. In more intensive management, especially say in the ICU, then you need to systematically do ABC. Uh, A is assess, prevent, and manage pain and use whatever it is needed to give analgesia. Then uh, B is for breathing and activity. And these have to be done as a spontaneous awakening trial, uh, you know, uh, give them breathing trials if they are on the ventilator so that you can bring them off the ventilator, and then use sedation very, very carefully. Now, one drug that I'm pointing out to you, though it may not be used in palliative care, uh, is uh, Dexmed. Now, the thing about Dexmed is, sorry, yeah, sorry, it slipped, it went ahead, but I'll come back to that. Yeah. What about non-pharmacologic strategies? Well, for palliative care and other patients, there are lots of strategies that we should be using. The first is optimizing sleep-wake patterns. So, increase exposure to daylight, reduce light and noise at nighttime, preferably use low-level lighting, then sleep protocols like massage and warm milk. All of these work. And probably the most important is that if the patient is in hospital, then to see that they get a bed which is near the window where they can be exposed to daylight. Even a hospice, I mean, the hospices I've seen have all been well lit places. This may be important if the patient is being managed at home. You may need to insist that the patient is brought into a place where there is enough bright light. The patient needs to be repeatedly oriented, explain where they are, who you are, what you are doing. You might want to put up a whiteboard and a visible clock so that they can see that. Avoid changing them around their location around. If they have eyeglasses, hearing aids, put them on. Mobilize as much as possible. especially sitting out of bed for meals. Restraints make patients very irritated. And if urinary catheters are placed, then you have to be careful to see that they don't immobilize them. Maintain and monitor hydration and nutrition, and monitor bladder and bowel function. As I said earlier, retention, constipation, fecal infection, all of these can worsen the situation. And obviously, somebody who's catheterized and is distressed by the pain of that catheter will also be continuously, uh, might just be delirious. And then you can involve the family, uh, show them how to manage the patient with calming voice. Their education and involvement will go a long way. Uh, of course, one of the first things that you do is figure out whether the patient's behavior interferes with care or safety, either the staff or the patient. And if that is so, then you need to plan. Uh, I mean, you might need to go directly for pharmacologic intervention. And here is where Dexmed comes in. Although it is rather expensive, and because of that, it's not often used in palliative care, it's probably the one drug that not only acts pretty fast and has, I mean, it can be used even in situations, say, for instance, like Parkinson's, where you cannot use haloperidol. So it's a drug that perhaps is best suited for the ICU, but I'm putting it here because otherwise it's not often mentioned in palliative care. Of the drugs that we do use, neurologists generally do not use haloperidol, even though it is probably the best drug that we can use, because if there is even a mild element of Parkinsonism, these patients will rapidly worsen, both in terms of becoming rigid, but also can develop the neuroleptic malignant syndrome. So it's got high potency. You can start with a small dose, gradually increasing it, going up to a maximum of about 4 milligrams per day. Generally, for me, I think about in the initial period only, sometimes we do go up to about 5 milligrams, say 2.5 or twice or one dose of 5 milligrams. It takes about 4 hours before you repeat the dose because of its pharmacokinetics, and then you start tapering it as soon as possible. The atypical antipsychotics, the new ones, are supposed to have lower uh, problems in patients with Parkinsonism, but I would still be very careful with them. If at all, olanzapine and quetiapine have been used. And in all of these, the target is a manageable but awake patient. And if you look, I've pointed out these papers at the end, so you'll be able to download them. The adverse effect for selected antipsychotics, look at how these stack up. So haloperidol is very good for sedation, hypertension, anticholinergic side effects. All of these are good, except extrapyramidal side effects are the highest of the lot. So anybody with Parkinsonian features, do not use haloperidol. Otherwise, haloperidol is generally the go-to drug. Chlorpromazine, hardly ever use it nowadays, but it's still used in palliative care units. Olanzapine, quetiapine, and aripiprazole are probably the drugs that we use most frequently. But in somebody who has Parkinsonian features, so somebody who has a neurological issue, then we have no choice but to try and build up clozapine. The only thing is clozapine uh, cannot be given as a large dose to immediately quieten the patient, and you have to build it up gradually. Uh, Amongst other things that we can do, as I said, I showed you the ABC. Now the DEF of delirium management. One is obviously monitoring uh, early mobility and exercise, together with periods of no sedation, and then family engagement and empowerment, so that they get cognitive stimulation and so on. What I do in somebody who is even mildly delirious is first find out if they are on a bed where they are getting daylight. If not, then I try and shift them there. Typically, when I'm using haloperidol for up to, say, somebody who's not really very agitated but a little irritable, is start with haloperidol 0.25 milligram tablets, 1 or 2 TID for 2 or 3 days, then BD for 2 or 3 days, and then HS for maybe you can go on for about even as long as a month. And you have to prescribe it with strict limitations on the number of days it can be given. And the caregiver is warned to hold the dose if the patient is drowsy. The other approach that you can take together with haloperidol is to add a Melocet, that's melatonin, 3 to 6 milligrams at I've written 6 to 7 p.m., but actually some people also take it as late as 8 p.m. But it has to be given about 3 hours before bedtime, and then it normalizes going to bed. Quetiapine can also be added. And if you do these three, there's one last element which I have not included, and that is uh, drugs that improve attention. So you would add one of those in the morning together with these drugs for sedation. Um, as I said earlier, uh, these beds have to be daylight, and then the last is to make a drug checklist. In palliative care, this is less of a problem because generally we cut out any drug that is visibly unnecessary for a long term, unnecessary for the immediate management. So long term drugs all go out, and if you, as a blanket, remove most of these unnecessary medicines, then you don't really you have to actually go through each drug and see whether it is required or not required. Specifically, the drugs that need to be eliminated or replaced are those that have high anticholinergic activity. So, if you have, if you are working in a palliative care unit and if you are faced with a patient of delirium, this paper is there in the list at the back at the end. And this is the full flow chart. One is, of course, preventive strategies. So you optimize the non-pharmacological approaches and the environment modification that I've told you about. And you need to continue to reinforce them. Of course, if somebody is likely to develop delirium, then you need to screen them regularly using a validated tool, which is taught to your nurses also. And there I recommend 480. You can warn the family also to look out for this, especially if the patient is at home care. And once the patient actually is uh, possibly affected, then confirm it with one of the tools like the CAM. It's again something that can be taught to nurses fairly easily. If the patient has severe delirium with a fair amount of agitation, then you have to figure out the various treatments that we have just discussed. And you have to monitor these patients for the adverse effects of these pharmacological treatment. Obviously, during this process, you start looking for potentially reversible or precipitating factors. And it will, of course, depend on the goals of care. And here you will deprescribe if there is a significant opioid burden, that consider opioid rotation. Of course, you can also use the pharmacological strategies that we discussed. And with all of these, you need then to start looking at potential delirium outcomes. Now, ideally, you will have a patient whose delirium completely resolves and can be returned to the community or to home. But you will recognize that a certain number of patients who have been through delirium for a longish period of time never really come back to normal, and they are left with long-term cognitive impairment. Did they have underlying dementia and it just got unmasked by the delirium? We don't often know, but these are patients who may not come back to normal. Of course, there are people who may be left in between, but probably the most difficult is refractory agitated delirium when it is clearly at the end of life. And this can be extremely distressing to the family. So you need communication, education, psychological support uh, for the family so that they understand what is going on. And for refractory agitated delirium, it is one of the indications for palliative sedation. I'm not sure if this has been taught to you or discussed with you yet, because palliative sedation is a major decision that I personally would not take at this stage unless I had a senior experienced palliative care physician with me on this. I'm going to stop by pointing out uh, three references which you've seen some aspects of in this talk, and all these three are free full text, and you should be able to download them and read them. I think I am a little over 45 minutes, and you will obviously, I'm sure, get the presentation from Pallium, but if not, you're welcome to email me or WhatsApp me, and I'll be happy to share it. Thank you. Can I stop
Thank
sharing?
you, sir. Yes, sir.
Okay.
So thank you, and you can ask any doubts.
And then we'll go on to the case. I think there was a case to be
This is a
presented.
very common problem which you usually see, and probably misdiagnosed or underdiagnosed. And I think you can ask questions about this. In the chat, there was one question that was regarding interaction of these drugs with morphine.
So, which drugs?
Probably with antipsychotics, I think, which you have mentioned.
There is a pharmacodynamic interaction. Haloperidol, I'll have to look up exactly which has interactions. Clozapine has significant interactions, I know, but the others I'm not sure about. I think that's a good point. I'll need to look that up.
Actually,
Anybody?
clozapine we usually don't use, but haloperidol is something which we used to treat opioid-induced nausea and vomiting. So it doesn't have much interaction, I think. Even quetiapine. Quetiapine, haloperidol, and risperidone. These are three drugs which commonly we use in palliative care, which doesn't have much interaction. But I'm not sure about the clozapine or aripiprazole, things like that, which we usually don't use.
Yeah, but you know, to my mind, see, if you are using morphine, then in any case, you will obviously have assessed the patient for delirium, tried to bring that to some extent under control, and the morphine dose you'll be titrating it. So even if there is an interaction, I don't think it's a significant issue. Now, any other question? And in fact, I'm looking at the list.
Interaction between cardiac drugs and quetiapine for QT prolongation.
Yeah. So with higher doses, you need to be worried about the QT prolongation. So typically, you will need an ECG at some stage. But again, that issue may not come up very strongly in a palliative care unit.
Yeah, actually, haloperidol produces QT prolongation, and some people advise regarding ECG monitoring, etc., etc. But we usually don't see much interaction with the dose we use, and maybe the patients whom we are seeing are mostly even in terminal delirium patients having. So we are not going to look at ECG for starting haloperidol in a terminal stage. And for doses which we usually use is low. So, but it is important to see that if you use methadone is a QT interval prolongation. It does prolong QT interval. And so if you use haloperidol, then maybe it is better to be aware that it can interact with methadone and increase the QT interval. Especially methadone has property to produce torsade points and sudden cardiac death. But this mainly the studies are mainly in patients who are on substitution therapy. So they will be on hundreds of milligrams of methadone. So low dose methadone may not be a problem, but if the person is taking high doses, then we should be more aware about it.
Okay, I think there was, yeah, so you answered the cardiac dozen could have been. Then managing delirium in epileptic patients. Again, this is postictal delirium. It usually is short lasting and it tends to settle down over a period of time. But if the patient is really aggressive, then you might need both restraints and haloperidol. Hypoactive delirium has, no direct treatment. You actually have to uh, try and treat the basic cause. But as I said, you can use daylight. Uh, you can use drugs like Ritalin and so on in the morning, together with basically you're regularizing the sleep-wake cycle as much as possible. And with that, some patients do start to wake up.
Yeah. So one important thing which I think all of you have to understand is previously we were using a lot of antipsychotics when a patient is diagnosed with a delirium. But now more and more literature are coming, and it says we have to first concentrate on non-pharmacological management of delirium. And antipsychotics are indicated if the patient has hallucination or if they produce self-harm or harm to others. So these are some indications now. New literature is indicated in or indication for antipsychotics. And Dr. Chetna says delirium in ICU is quite common. Yeah, it's very common because of many factors involved. Patient doesn't have the awareness about day and night, and usually it is well lighted 24 hours, and the stimulation from various places, many nurses, many drugs, many sounds, etc., etc. All those are predisposing to the delirium. Can olanzapine worsen delirium in elderly? Some case reports in malignancy cases were reported in advanced prostate cancer.
I suppose any sedating drug can worsen delirium. So you have to be, it's a bit of judgment about how much you're using. And if there is no evidence of Parkinsonism, clinically or otherwise, that's one of the reasons for preferring haloperidol. The sedative effect is probably the least of all the antipsychotics. Yes.
Any more questions? So if there are no more questions, I think we will move on to patient story.
Yeah.
So Rajalakshmi. So the patient story will be presented by Dr. Isaac from Emmanuel Hospital Association. Dr. Isaac?
Yes, sir. Can I start with my presentation?
Yes, please.
Yes.
Good.
Okay. Good afternoon, everyone. So this patient was treated at our hospital. He's a palliative patient diagnosed with multiple myeloma around 4 months back. He's 84 years old. He had come to our hospital with urosepsis and delirium. So his presenting complaints, he had disorientation. He was oriented to time and place, but he was not oriented to time and place, but he could identify his caregivers. He had a history of disturbed sleep. The caregivers were saying that he was awake during the daytime and awake during the nighttime, and during the day he was sleeping, and also with lack of appetite. Um, so it had started with he had actually a fall in the bathroom, which led to a fracture of his neck of right femur, for which they actually tried to take him to hospital for surgery, but the doctor suggested conservative management. So he was bedridden and was catheterized. Over the course of week, he gradually lost his appetite, and the relatives noticed that he also had excessive drowsiness and trouble sleeping at night. And he eventually lost orientation to time and place. The past history, he's a known case of diabetes and hypertension, and on medication for over 10-15 years. He was diagnosed with multiple myeloma about 4 months back, and they didn't want to go for any particular type of treatment. So he was on home-based care, and the fracture happened 1 week back, and it was managed conservatively by traction. Next slide, please. On examination, he is a tall and thin-built person. He was quite drowsy on presentation, and pallor was present, no icterus, cyanosis. He was conscious, but he was not oriented to time and place. He could identify his relatives and the people who were caring for him, as well as responding to verbal commands. His GCS was 13/15, and his reflexes were normal. BP was 140/60, pulse rate was 80, saturation was maintained, and his GRBS was 212. On investigations, his electrolytes were kind of deranged. So he was started on a high salt diet with fluids. He was started on antibiotics also, cefuroxime 1.5 gram, Q12 hourly, and as well as Pantop. And the orthopedic treatment was continued with the traction given with a boot cast around 3 kg. Also, bedside care, sponging, and oral care was also given. Next slide. His psychosocial aspects. He's a retired government officer. Lives with his son's family. His son is actually the director of a quite reputed government institution, and they are from a very influential family who want like the best care for their patient, and also financially they were quite well to do. On treatment, his electrolytes picked up quite a bit, and eventually he was discharged on like the medicines he was already on, as well as PCM for pain management. So the main concern is the family were quite apprehensive, and because his delirium happened quite suddenly, and they were quite apprehensive that whether it was the last stage for the patient. Also, from the patient side, the patient feels he's like a burden to the family, since he already has cancer and he's right now bedridden. So summarizing, he's a 84-year-old gentleman with a known case of hypertension and diabetes, diagnosed with multiple myeloma, and having a pathological fracture of the right femur with complaints of disorientation and disturbed sleep. So the discussion points are how to treat delirium, also other mental illnesses like Sir had mentioned depression, dementia, and psychosis in palliative patients. How to deal with family's influence over treatment options, especially in cases where the family is like quite influential and well-to-do. They try to control what the patient does, as well as what the doctor's treatments should be, as well as how can quality of life of a patient be improved in like these cases. Thank you.
Okay, thank you, Dr. Isaac. So, anybody want to ask any questions?
I thought I was asked one question. I've just
Yes,
put it
sir.
up there.
Yeah.
In this
Okay.
individual, how many risk factors could you count? Does anybody want to have a go? Because I did.
Yeah.
Dr. Isaac, would you want to run through the slides? Just take 5 seconds over each slide. Don't say anything from the beginning. And could people just count? Yeah, go on. Start. Next. 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 Okay. So, anybody wants to unmute themselves and tell me the risk factors that you could see here?
So I see there are some comments. One is
Yeah. So people have given. I'm asking the number.
yeah.
How many? How many risk factors? Somebody said 9. Well, I think I got 8. So you got one more than me. Take. Yeah. So I'll just quickly go back over it. It is. I'll tell you what I could see, and there was, of course, the question of his age. That's one. Then 2, probably disturbed sleep over a period of time. Then the fracture and the pain related to it. So that would be 3. I'm not actually counting comorbidities here because but the fact that he was immobilized was number 4. That is significant. Then anemia, that was significant, 5. Then I'm not sure if you count CRP, but hyponatremia is definitely there. That's 6. And then there is the fact that he is on benzodiazepines. Together with duloxetine could also have an anticholinergic. So drugs, 7, and maybe an element of depression. So 8. So anything? Somebody said 9. Any one more that you could count? You want to point that out? No. Yeah. So you counted comorbidities also. Fair enough. So yeah. So in that sense, you can look at all these risk factors, and this is important when you are both. If you're looking at prevention, and obviously if you're looking at treatment also. But if you look at treatment, then you're probably focused more on the issues that have come up relatively recently in this patient. And here, the 2 that have come up immediately, quite rightly from the unit that's presenting, is hyponatremia and the urinary tract infection. And those are, plus of course, clearing up the medication list and perhaps treating the anemia. From you. Hello. Yeah, Dr.
Yes,
Sunit, anything?
Yeah, I think he had a fracture, so probably treatment of pain, and because of immobility, and pain. He might have constipation. I'm not sure, even though it has not mentioned here.
Yeah, so pain, yes. And yeah, we could, of course, treat pain with a simple, I mean, even paracetamol would probably work for somebody like this individual.
So, sir has already mentioned about the treatment of delirium. So, we need not discuss that here. Would be how to deal with families' influence our treatment options. I think, Isaac, what happened with family? Can you explain? Was there anything happened?
So not specifically, but the parents were quite the son's family basically. They wanted everything done in a particular way. Is it like no? I mean, the behavior is normal, but is it at least in palliative settings? Do we do it in the families according to families' wishes, or do we try to keep them more according to medical treatment,
Uh,
according to what doctors will say?
Dr. Sunil, you want to handle this? All right.
Okay, okay. I would tell you a recent experience. A patient who was admitted here having an advanced Parkinson's disease. Uh, he was 83, I think. And he was admitted saying he is not eating, he is drowsy, urine output is less, things like that. The daughter is a psychologist. And the problem with that, if we do anything, we have to discuss with the caregiver. If you do anything without asking the caregiver, then that would be a problem. So it is not only with this patient, for any patient, we make it a point to discuss with the caregiver so that there will be a trust between us and the family. So it will be easy for us to take any decisions, and that also shared decision making, which is very important, not only in palliative care but also in any specialty. So I think it is important for us to talk to the family and get or make a good rapport with the patient and family. So that's the best way to deal with uh, uh, patient problem. Uh, we have to understand that patient and family are the people who decide treatment. We may see that, okay, there are many treatments available and we want to do this. But if the patient and family says, okay, we understand that this treatment has to be done, but we don't want that, knowing that without doing this treatment, he may even die. And considering the autonomy, then if the patient and family has good mental capacity, then we have to obey the decision.
Yeah, so one thing to remember is that while the patient is delirious, the patient is not really in charge. Otherwise, your duty is to ask the patient. So as the patient patient's autonomy is compromised, you have to depend on the family for all your decision making. And as you go along through palliative care, you will realize that as you learn the various tactics for communication skills, you will actually find it easier and easier to bring these into play when this family gets concerned. Now, one of the things that you might want to go back and look at the son and try and find out, why is the son so concerned? What is it that he's concerned about? Is he concerned about his father's distress? well, that's something that we can handle. But you need to be aware of what their concerns are and where those concerns come from. And it's what Dr. Sunil Kumar said is perfectly valid in the sense that in palliative care, we reorient ourselves away from uh, cure. But when we orient ourselves towards care, you have to remember that we are not looking at the patient in isolation. We are looking at his ecosystem also. And if the family, and you can see the fact that for him, one major source of distress is the fact that he feels he's being a burden. So you can see the dynamics between him and the family and the way it works. And uh, it's not very difficult to address them once you know how to assess and then intervene. And I think as you learn, as you get more and more involved in palliative, you'll find this happening more and more easily. Quality of life.
Thank you so much, sir. Also, I think since there were a lot of points to be considered, treatment options, I think the family also was quite tensed on what treatment should be done. Also, I think with COVID, the son wasn't very keen on keeping the patient at the hospital, and they were trying to like look at all the other options that they could do, like for care for the patient.
Right. So we did discuss mobilization. See, unfortunately, given the way the fracture is, it's impossible for the patient to be physically, I mean, to be sitting up or weight bearing or anything. But what can be done within limits is passive physiotherapy. And I'm sure that very often families miss out on. They need to be actually shown. And one easy way to do that is to there are YouTube videos which show you a sequence of passive physiotherapy, and that together with light massage makes a lot of difference in comfort. Quality of life. So again, Dr. Sunil, do you want to? Anybody wants to comment on how what we can do about the quality of life of this individual? Simple things.
Anybody
Any
can answer?
suggestions?
Yeah. Interaction
Interaction between.
patient and family.
So how would you encourage that? Uh, typically, yes. Typically, the old gentleman would be in his room, probably at the back of the house, where people pass in and out. You have to encourage them to see that he's brought um, into the family space as much as is possible, so that he can interact with them. Yeah, read a newspaper, put the TV on. Yeah, all of these things. The family members being given assigned duties to spend time with him and to talk to him, all kinds of things. In Indian families, one very simple thing is one of the grandchildren uh, is moved into the same bedroom, which is I think quite nice. Yeah.
So one point which I would like to add is quality of life is something which is decided by the patient. It is decided by the person, not by us. So we have to ask each person or the family what is the um, most important thing for this person that can enhance the quality of life. He may not want to walk again, but as I told, seeing the grandson, that would be that from his perspective, that may be the thing that is going to improve his quality of life. But I think you are talking from the point of view from delirium. But when you address all the factors involved in precipitating delirium, he might come back having a good quality of life.
Right. So one last thing. Obviously, the gentleman is at this moment uh, delirious, but at some stage, as his delirium wanes, um, and say, for instance, if home care is available, and that individual is followed up, uh, at some stage, I would do a systematic palliative care needs assessment also, finding out what are the various symptoms that he has, addressing the various symptoms that he has. And that is something that we don't often do systematically.
Okay. Uh, so, Sir has mentioned that passive physiotherapy and massage has a role. But if this patient is able to walk, then early mobilization seems to be very important
Very
for
important.
relieving delirium. So,
Very, very important.
patient should be assisted by a caregiver and then allow him to walk. So, that's
Sir,
also an important factor.
sorry, sir, regarding music, actually the patient felt much better listening to old recordings and like classical music.
Mhm.
I have regarding role of music in mental illnesses also.
Mhm.
Yeah, so
Yeah.
you can ask the family what the patient enjoyed, no? And then see if you can get that back. But very often the patient uh, also needs to be asked what they would want at that time. And as far as choices are concerned, uh, well, uh, I at this stage I would probably not. Uh, uh, I think this is Dr. Savera Ahmad said the patient's choices can be asked. Um, what kind of choices were you speaking about in terms of entertainment activities or something bigger than that?
Dr. Savera Ahmad.
Okay. So one is, of course, simple choices about what entertainment and so on. Obviously, even somebody in delirium can easily communicate that. But this is, if you're looking at bigger choices about future care and stuff like that, um, this is probably not the stage to discuss this with the patient. Right. Uh,
So can I
Dr.
ask
Sudeep?
a question?
Yes.
Yes, go ahead.
Yeah, sometimes we have found that in delirium, they go into a deep sleep like for 15 hours, 16 hours, and after that they make a good recovery. Why is it so? Because,
Fluctu-
yeah,
so
they just,
fluctuations do occur, no? So the fluctuations can sometimes be quite prolonged. So you have individuals, I've had patients who slept for as much as 24 hours and then, so basically the sleep-wake cycle completely gets disrupted and the extreme cases are very prolonged sleep-wake cycles.
so, but then they can make a recovery post that
Yeah,
sleep.
once the precipitating factors are controlled, then they do come back to normal. So delirium in its sense is not a permanent damage, unless of course it is due to some kind of CNS injury. Otherwise, it's usually a temporary thing.
Okay, sir. Thank you, sir.
So, any more questions? Okay, Dr. Chadana says ICU delirium recover in 1 day also.
Yeah, depending on the cause, it's quite possible.
So I think we can wind up this session. We were talking about delirium during the lecture as well as for the patient story. So that was good to have a same case history for discussing delirium. And thank you, sir, for your wonderful session on details about delirium, how to assess, how to manage, what are the features, what need to be careful, what are the non-pharmacological management, what are the things that need to be careful while using medications, etc. So thank you very much. And thank you, Dr. Isaac, for coming up with a good patient story. And thank you all for your interaction. And thank you all. We'll see you on next Tuesday.
Next Wednesday, sir, with the topic on organizing palliative care. Thank you all for joining in. We'll see you next Wednesday. Bye.
Bye.
Bye-bye.
Thank you, Dr. Sunil. Bye.